And it's a pleasure to have you here. Thank you very much.
Thank you for the invitation. I was initially asked to talk about the severity of aortic regurgitation assessment, and I've seen in the program that it was only assessment of the aortic valve. So I will stick to the severity since Jibrin will be giving you the pathology later on. So I will give you an echo and imaging talk. But I think that this is very important for surgeons to really understand how we make the diagnosis and how we quantitate, because you don't want to make the wrong decision when you go for the intervention. So let's start with echocardiography. As you can see here, there are quite a few methods to assess the severity of aortic regurgitation. This means that none of them is perfect, and they should be used in combination to come up with the right diagnosis. And I will go across most of them very briefly to show you how we do that. So the first method that is very often used by cardiologists, but I think it shouldn't be used to make the quantification, is just to look at the size of the jet into the left ventricle. So we will look in color how the jet is moving into the ventricle, how deep it's going, and make our assessment like that. So in favor of this technique, it's very easy. You just have to push on the color button. It's fast, and it helps to assess mechanism. This is very important because any centric jets needs to trigger your attention on the possibility of having a valve prolapse there. Against this type of measurements is that you can make, by just simply modifying the settings of your echo machines, this aortic regurgitation appears or disappears, look mild or look severe. So it is impacted by instrumentation factors, and it's semi-quantitative, and I just will illustrate that with mitral regurgitation because I don't have an example with aortic regurgitation. In general, there are 4 grades when you do that, from 1 to 4. And you look at the jet, which is here, this mosaic, a little bit greenish jet. The aortic valve is there. And not to be confused with the mitral inflow. So very often this is quite difficult because you would think this is going to the apex of the left ventricle. In fact, this is the mitral inflow, and the aortic regurg is only located here. In general, we say that a small aortic regurgitation is the one confined to the LVOT. If it extends to the tip of the anterior leaflet, it's grade 2. If it goes to the papillary muscle, it's grade 3. And if it goes beyond the papillary muscle, it's called grade 4. But as I said, there are several factors from the machine that can affect the appearance of the jet, and this is for mitral regurgitation. The first which you have to look at, although you're not echocardiographers, but you're looking at these images every day, is the encoding velocity. And you see here it's 60, that's the right one. It should be the highest possible for the machine. And you see that for this mitral regurgitation jet, it looks moderate. If you decrease that, it's very easy to do, to 33 centimeters per second encoding velocity, you see that you're already looking at a severe mitral regurgitation. And if you go down to 16 centimeters per second, it really looks a very, very severe one. So you can go from grade 2 to grade 4 simply by changing the settings of your echo machines. And this is relatively easy when somebody comes to you showing you an echocardiogram. You have to look at this encoding velocity. And if it's lower down to 50, 60 centimeters per second, it's true for mitral aortic regurgitation. You should discard this examination because it's probably misleading. The gain is also important. Just by turning the gain down, you can make this mitral regurgitation disappears, or putting the gain too high, you can have very severe mitral regurgitation from one which is actually only moderate. The second method is to measure the flow across the aortic valve and across another valve orifice. Usually it's the mitral orifice. That's the quantitative method. It's well validated. The trouble is that it's complex. You need to make several measurements of dimensions of annuli, of flow velocities, etc. So it can be compounded by errors, and particularly the addition of all the errors in the same direction. So it's a relatively easy method. You measure the flow across the aortic valve by measuring the size of the LVOT and the velocity across the valve, and you do the same at the level of the mitral valve, inflow, outflow, and you make the difference between the two, and that gives you the regurgitant volume. quite easy, but unfortunately a lot of errors in the measures. One thing that we do each time, I am not sure it's really something that will help, is to look at the flow reversal in the descending aorta. And you know that if there is regurgitation, or of course there will be backflow in the descending aorta as well. And if you do so, you can see whether or not you have one. And usually in mild to moderate AR, you do not have an holodiastolic flow reversal in the descending aorta. And you can also, if you've seen one, measure the velocity at which, and if it exceeds 20 centimeters per second, that's an indication of severe aortic regurgitation. Then there is the pressure half-time method. It has been used for years, and I think it's still a useful component of the assessment of the severity of aortic regurgitation. The principle is relatively easy. I see that the format of the slides has changed, but that's not important. In diastole, where the regurgitation occurs, you have a gradient between the aorta and the left ventricle. And if the aortic regurgitation is severe, then this gradient will vanish more rapidly during diastole than if it's a mild aortic regurgitation. And you know that the continuous wave Doppler recording is measuring the instantaneous velocity across the valve, which is immediately related to the instantaneous gradient. So the shape of that regurgitation jet here with CW Doppler is the representation of the pressure difference over time between the aorta and the left ventricle. So if the depressurization of the aorta is slow, that means that we have mild aortic regurgitation. But if the slope is very steep, that means that we have a very severe aortic regurgitation. This is an example of two different cases in which we can measure the time for the decrease to half the pressure, which is pressure half time. And you can see in these two cases that we can measure two different things simply by tracing the line of the deceleration of the flow. Now, in the guidelines, we know that mild aortic regurgitation will be a pressure half time which is very long, so a quite flat deceleration, versus a severe aortic regurgitation in which the pressure half time will be less than 200 milliseconds. You see, there's a huge gap between 200 and 500. Between 200 and 500, we don't know whether it's severe, mild. It's probably moderate, but there's a huge uncertainty there. So it helps. It's not on this basis that you should make your final assessment. What is much more interesting is the assessment of the proximal jet characteristics. It can be essentially the proximal jet in the LVOT or the vena contracta. I will just show you an example of a very severe aortic regurgitation. You see here that both in the short axis as well as in the long axis view in this transthoracic echo, you have the flow that is occupying the entire LVOT. By no doubt, this is severe aortic regurgitation. You don't have to make any quantification. It can be interesting to measure the size of the jet at its smallest part, what we call the vena contracta. That vena contracta is a little bit beyond the orifice. You know, when the flow streams to the orifice, it accelerates, and then it needs to converge. And of course, when it reaches the anatomical orifice, it will not stop converging at that very point. It will still continue converging for a few millimeters until it reaches this small dimension, and this is the vena contracta. And then it will spread out in the LVOT. So we can make the measurement of that. That's the vena contracta measurement. And you take the jet and you measure the smallest size beyond the orifice or at the level of the orifice. And the value for severe aortic regurgitation is 6 millimeters. And it's a very convenient way of doing that, particularly in the operating room, where it's not always easy to get the PISA. And then if you have recurrent aortic regurgitation or residual aortic regurgitation at the end of your operation, you can make that measurement quite easily, much more easily than you can do with the PISA method. Finally, you've all heard about the proximal isovelocity method, which is the PISA method. And this technique will calculate two parameters, the regurgitant volume and the effective regurgitant orifice area. For this, we're going to trick the machine. You know, echo machines are very nice, but they have a lot of drawbacks. And particularly when you encode velocity in color, you're limited by a what we call a Nyquist limit. At this level, you cannot evaluate the velocities anymore, and in color, the color will change from, example, from blue to red, or from red to blue. At this very level, you have the velocity that is being shown. It's not shown here, yes, it's shown here on the scale, by the machine. This is the velocity at which the color will change from one color encoding to the other. This is simply a limitation of the echo machines, but we will use that limitation to be able to quantitate the volumetric flow rate across the valve. And how we do that? Well, I cannot read the exact number here, but let's suppose it's something like 30 or 40 centimeters per second. So to do that, I will change the baseline so that we have the color in aortic regurgitation, in this case, only it's an apical view, only in blue. So this is the acceleration zone. Before the orifice, the flow will progressively accelerate towards the orifice. And it will do that in an isovelocity manner. So several shells, like an onion, with different velocities, increasing velocities as you approach the orifice. And of course, at one point in time, the velocity will be exactly the one at which you have this color coding change imposed by the machine. And so you can beautifully see the boundary between the blue and the red. This is because all the red blood cells at that very level have the same velocity. And what velocity? The one that is shown by the machine, and I cannot read, but probably something like 30 or 40 centimeters per second. Now you know the velocity of the red blood cells at that level, and you know the hole is located here, so now you have the distance between this shell and the hole. That is the radius of a hemisphere. And at that level, every red blood cells have this 30 centimeters per second velocity. So now you can calculate the flow rate because you can calculate the surface of this hemisphere. You have the radius, so the surface of a hemisphere is 2 times pi square. And then you have the velocity. And if you have a velocity in centimeters per second multiplied by square centimeters, you get centimeters cubic or mLs per second. So now you have a flow rate. And if you divide that flow rate by the peak velocity of the jet measured with CW Doppler, you get the effective regurgitant orifice. Why? Because you have centimeters cubic per second divided by centimeters square per second. This leaves centimeters per second. That leaves you with centimeters square. So now you have the size of the hole. This is the size of the vena contracta. And if you multiply that by the time velocity integral of the jet, so the entire planimetry of the jet, you multiply that, this is in centimeter, you get the regurgitant volume in ml. So 2 parameters are given by the Pisa method, the ERO, effective regurgitant orifice, and the regurgitant volume. And you see that in most of the cases in patients, there is an excellent correlation between the ERO measured by that technique and the ERO measured by the Doppler technique. There is one situation, however, in which it doesn't work, and it's very important. These are the prolapses of any of the cusp, either in tricuspid configuration or bicuspid configuration. This is a typical example of an anterior cusp prolapse, which is a distal cusp prolapse. You see that there is a bending in the cusp and that the distal part is going below one of these posterior leaflets. This gives a posteriorly oriented jet that goes towards the mitral valve and is impossible to quantitate from the apex like it is usually done. You need to do that from the parasternal view or the retroesophageal view like in this example. And we've compared in an analysis some years ago, commended by the guidelines, and compared that to the parasternal view like I've just shown from this TE examination. And you see that there is a lot of noise in the CW Doppler signal when you assess that from the apex, essentially because the jet is going almost perpendicular to the ultrasound beam, so it cannot be really assessed. And in this, from the left parasternal view, you see that the jet is going down and exactly in the same direction of the ultrasound beam, so we ideally placed to make the measurements. And when you make the assessment from the apex using the CMR, so MRI as the reference, you see that there is clear-cut underestimation of the regurgitant volume measured by the Pisa method. And this is even more nicely shown here. If I only look at the central jets, you see that PISA and CMR from the apex are giving exactly the same amount of regurgitant volume. But if you look at eccentric jets from the apex, the PISA is underestimating by about 30 to 40% the severity of the regurgitant volume, and this is completely corrected if you did that from a parasternal view. So you should be aware that if the assessment by your cardiologist is done only from the apex in eccentric jets, it's going to be wrong. And if you do the assessment from the parasternal view, you get a beautiful relationship between the two. So which are the threshold numbers? Well, the threshold numbers is 60 mL for severe aortic regurgitation in terms of regurgitant volume and 30 millimeters square for the effective regurgitant orifice area. Just a few words, if you cannot do that by echo, you can do that by MRI or by CT. For this, we will measure the orifice by planimetry. And you can do that very easily on the CT because then you have the 3D volumetric information and you can reconstruct it the way you want. And you need to make several cuts so that you have a perfectly perpendicular assessment to the orifice. In central jets, it's easy. In eccentric jets, you need to adapt your cutting plane. I will show you that. So in eccentric jets, like in this one, you see there is a prolapse there. The orifice is located here, but it's not parallel to the plane of the aortic annulus. So you have to adapt your cutting plane to be able to see the orifice from an en face view if you want. And you can do that in several different situations. For instance, in patient with type 1 dysfunction, so mainly dilatation of the ascending aorta, you see here that the sinotubular junction has vanished. And then in this case, the jet was central, and we could make that cut very parallel to the plane of the aortic annulus. And then you freeze in diastole, and you can make the planimetry very easily of that regurgitant orifice. A bit more tricky in patients with a prolapse. This is a bicuspid Cos Prolapse. You see that the orifice is probably lying in that direction. So we made the cut plane in that direction to see an en face view of the regurgitant orifice, and you can then make the planimetry of it. This is a type 2 dysfunction. This is a type 2 dysfunction as well, but in a tricuspid configuration. And you can beautifully see the prolapse that is seen at that level, and then we make the plane cutting through almost perpendicular to the aortic plane to get a beautiful view of the regurgitant orifice. You can do that by MRI. It's a bit more tricky because you have to program your sequences. We rarely do a 3D MRI because of resolution problems. If you do so, the comparison of the ERO measured by PISA and by MDCT is excellent, and the same holds true for MRI. So you have an alternative method to make that assessment. If you cannot do it with echocardiography, you can make it by tomographic imaging like CT or MRI. So this is my last slide. As I said initially, when you make this assessment, emerging body of evidence, you need to have several different methods that have been used with echo or other types of imaging methods that will lead to the conclusion that you are dealing with severe aortic regurgitation. And severe aortic regurgitation is a very large jet, one with a vena contracta that is more than 6 millimeters, one with a pressure high, with a hollow diastolic flow reversal in the descending aorta. I don't know why the format has changed so much, and with enlargement of the left ventricle. This is very important. And then, of course, you can make all the measurements from a quantitative point of view with the regurgitant volume and the regurgitant orifice area. So when I see a patient in my outpatient clinic with an aortic regurgitation, and until now, I'm not very aggressive in operating on patients without any symptoms because this is a disease that is very well tolerated for years by the patient. It's completely different from the mitral regurgitation. When I see one of these patients, systematically I calculate left ventricular volumes. When I measure left ventricular volumes in systole and diastole, I have their total ventricular output, so the antegrade and retrograde simultaneously stroke volume, and then I measure the PISA and I calculate the severity of aortic regurgitation by several means, and I try to see whether or not this works together, that the numbers do fit, because if they do not fit, there's probably a problem. So it's impossible to have a regurgitant volume of 80 mLs in a ventricle that is large, like 120 mLs in the diastole. If you have 20 mLs of regurgitation over a normal left ventricle, which is 120, 140 mLs, you should all the time have at least 200 to 220 mLs of end-diastolic volume. It's impossible also to calculate 80 mLs of regurgitant volume if your total stroke volume is also 80 mLs. So if these numbers do not fit together, then you are in problem. So I think this is an integration, a comprehensive assessment, and not simply one simple measure. And everything should be made to make that quantification as accurate as possible. I thank you for your attention.